Life is unpredictable, but how you prepare for the unexpected shouldn't be. Take ownership of your life planning with Policy Genius to help your loved ones have a financial safety net in case something happens to you. Whether to cover debts and routine expenses or even invest the money and earn interest over time. With Policy Genius, finding and buying life insurance is simple. You can compare quotes from top insurers and could find coverage that fits your needs and your budget. Plus, they offer life insurance policies starting at just $276 a year for $1 million in coverage. It's an easy way to feel good about and plan for the future. No wonder Policy Genius is the country's leading online insurance marketplace. Don't wait for life to make other plans. Protect your family today. Head to policygenius.com to compare top-rated life insurance policies, get your lowest quote, and make a smart move in under 10 minutes. That's policygenius.com.
Hello, everyone, and welcome to Talk Nerdy. Today is Monday, August 25th, 2025, and I'm the host of the show, Dr. Cara Santa Maria. And like I always say right here at the top of the show, I do want to thank those of you who make Talk Nerdy possible. Remember, this show is and will always be 100% free to download as long as I am able and willing to keep producing episodes. Gosh, we've been doing this for 11 years now. Today's episode is actually number 565. So yeah, as always, I want to thank my top patrons of the week. They include Anu Badavaj, Daniel Blell, I just mixed up two names. Anu Badavaj, Chuck Blell, Daniel Lang, David J.E. Smith, Joseph Lamore, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo, Joe Wilkinson, Pasquale Gelati, and Ulrika Hagman. And of course, there are hundreds more of you who keep this show going. I thank you so much from the bottom of my heart. All right, let's dive into it. This week's episode is one that's very near and dear to my heart, one that's very interesting to me as a psychologist and as somebody who studied neuroscience before I went back to school. This week, I had the opportunity to chat with Dr. Virginia Sturm. She is the John Douglas French Alzheimer's Foundation endowed professor in the departments of both neurology and psychiatry and behavioral sciences at the University of California, San Francisco. So she's an affective neuroscientist and neuropsychologist at the UCSF Memory and Aging Center, where she focuses on research involving emotions, empathy, and social behavior, but specifically with neurodegenerative disorders and neurodevelopmental conditions. She recently co-wrote a book with her colleague Bruce Miller called Mysteries of the Social Brain: Understanding Human Behavior Through Science. So without any further ado, here she is, Dr. Virginia Sturm. Well, Virginia, thank you so much for joining me today.
Thanks so much for having me.
Of course, I am excited. I'm always excited as a psychologist when books come across my desk for the podcast that are what I would consider good science books, right? Because this show is and has been since the beginning sort of a public science communication podcast. But I'm always excited when those books that come across my desk also touch on my own personal areas of interest. So I am a clinical psychologist, but was trained in neurobiology first, like at the master's level before I went on for my PhD. You are an affective neuroscientist and neuropsychologist. Tell me a little bit, or tell, I guess, the audience, because they probably really don't know the ins and outs of the difference between, like, what is cognitive psychology? What is neuroscience? What's a clinical versus a research psychologist? Kind of what was your academic path?
Sure. Yeah. And it is a really complicated field and with lots of different variations of similar titles and roles. So my graduate work and PhD was in clinical psychology also. So clinical science specifically, which is the most research-oriented form of a clinical psychology program. So in a clinical psychology graduate program, you learn not only how to do research, usually on a clinical question or in a a group of people with some type of clinical symptom like depression or anxiety or a disorder such as a dementia, like I study. But you also learn how to do clinical work, meaning you learn how to do therapy sometimes. Other times you learn to do neuropsychological assessments. And that means that you do different tests to figure out how someone's brain is functioning and different areas, how their areas of cognition are kind of operating. So you also learn how to teach students and mentor. So there are a lot of components to becoming a clinical psychologist. Neuropsychology is a form of clinical psychology that is even more focused on the brain and trying to use cognitive tests and behavioral observations to figure out where a brain might be working well and where a brain might not be working so well. So often that happens after graduate school in a postdoctoral fellowship. That's where I did mine in a clinical internship, which you do after you finish your graduate research. So there are other areas of psychology, like you mentioned, like cognitive science or neuroscience, and I also do neuroscience in my research. And that just means maybe you have less of a focus or interest on a clinical group. So you might just be wondering, like, how does memory operate in people with who are left-handed, or some kind of basic question about cognition. Or you might be wondering, like, what network in the brain supports that ability if you have a more of a neuroscience focus. So in the end, we all work together and we all can ask similar or complementary questions, but there are different like paths and routes to get there.
And so are you now doing clinical work, or are you focusing more on research, or are you doing both?
I focus mostly on research now, but as a neuropsychologist, we do neuropsychological testing both in our clinic. So people who come in wanting a diagnosis and wanting to be treated and followed for a memory complaint or behavioral change. But we also do the similar kinds of tests in our research setting. So that just means that in that context, we're analyzing that data with other groups of people in order to find, different patterns, and then we write papers about that. So I do neuropsychological assessments in a research context, which is more aligned with my laboratory-based work, which is what my own personal kind of interests are in.
And so speaking of those, personal interests, when we talk about neuropsychological assessment, it really does run the gamut, right? And a neuropsychologist is trained in having a sort of broad understanding of the relationship between brain and behavior. And then given the pattern of responses and scores on these different tests, different kind of patterns emerge. And so then they can narrow in and say, oh, this looks like something kind of ADHD, or this might be a dementia issue. I'm seeing some memory deficits over here. What specifically, and as a clinician, you may have an area of focus or you may be more broad, but as a researcher, you definitely have an area of focus, right? You have research questions that you're interested in answering. So what are those topics that you've mostly focused on, or that you continue to focus on?
Yeah, my research focuses primarily on emotions and social behavior. So when I am working clinically with someone doing neuropsych testing or cognitive testing, I am using my same, interests and skills to observe behavior and make hypotheses about whether, their behavior or facial expressions, things like that, are within the normal range of what we see in most people, or if there are things that are kind of that stand out to me as perhaps indicative of some other disorder that we often see in our clinics. So the research and the clinical kind of always go together, and in the best worlds, those two hats that we wear kind of really complement each other and help us to ask better questions in both situations. So my clinical experience always guides the questions that I ask in research. But in my research, we take a different approach than we do in a regular neuropsych kind of context. So we bring people into a lab and we attach lots of sensors to their hands and their bodies, and we videotape their face, and then we try to make them feel various emotions. And we do different kinds of tasks to see how they react to different social information. And we're always trying to figure out, like, for an individual person, are there areas of weakness in any of these domains that we assess, either in how their body is responding to something like an image that often elicits empathy, or in their facial behavior, or their strengths. Some people are really strong in their social and emotional skills, and we like to always look for strengths. And then once we figure out kind of their profile, we can look with images or MRIs of the brain to see where different parts of the brain might correlate with the measures that we've acquired in the lab.
And so are you looking at just kind of everyday people, or are there specific populations that you're interested in understanding sort of their connection between the social and the emotional and the, I guess, neuropsychological correlates of that?
Yeah, most of my work has focused on individuals with what we call neurodegenerative disorders. So these are progressive problems in the brain that usually lead to dementia. The most common neurodegenerative disorder is Alzheimer's disease, which affects many people in the later decades of life. But there are other disorders such as frontotemporal dementia, or FTD, that often arise earlier in life, when people are in their 50s or 60s. And FTD really affects the parts of the brain that allow us to be empathic and kind, generous people. And so when those systems deteriorate in the context of this disorder, people can become different than they used to be. Their personalities change, their families describe a profound sense of loss in the loved one who they once knew is no longer there anymore. So that's where most of my work has been. We always compare people with these different diagnoses to regular, healthy, for us, usually older adults who are volunteers in the community who are kind enough to participate in our studies, so that we have a nice comparison group to know, how does the average person react in this kind of situation? And then we can figure out, well, in this disorder, such as FTD, there's really dramatic differences in how they respond to, this movie that usually makes people feel empathy, for example.
Right, right. And so I'm curious how much of your personal work made it into this book that you co-authored with Dr. Bruce Miller, and how much was this sort of a project that you guys felt compelled to do that's a little bit separate from your work and more, I guess, a lit review, or like kind of just the current trends in the field?
Well, we tried to integrate, what is known from the field more broadly, but the core of the book definitely came from our personal experiences. Dr. Miller is a neurologist who runs the UCSF Memory and Aging Center here, and I've been fortunate enough to work with him for really over 20 years. It was my first job out of college, was working in this exact center, and I've kind of continued on through graduate school and as a faculty member, continuing to work with these same clinical populations, because it's such an interesting kind of area there's so much we don't know about the area of the social brain and how the social brain operates. And that's what we really focus on in the book. So the stories in the book, the clinical stories in the book, were primarily from patients that he had seen over his career. Some of them I had seen as well in more recent, years. But the research that we integrated was really based in both of our work, in addition to from the broader field.
Yeah. Okay. And so talk to me a little bit about how you guys, I guess, organized your thoughts for a book like this, because it's a really readable and like not just accessible, but just literally in terms of like the size. It's a short and not overwhelming volume, and so there's so much to potentially put into a book like this, right? Like the social brain. How do we understand human behavior through psychiatry, psychology, neuroscience, neurology? How did you choose what you wanted to focus on and what you were kind of okay leaving out?
Yeah, it's a really great question. And I would say it was a long and iterative process of trying to highlight the most compelling stories and people that had taught us the most about the social brain, because there are some of these people that we meet who are so striking in what changes occur, in their lives because of these diseases. We all just learn so much. We learn volumes from like one individual. And I think that's a kind of meta theme of the book, is that in research, we usually study groups of people, and, we average whatever measure we've collected. We take an average in the group and we compare groups, and we find, oh, this group is high in this or low in that. But really the individual stories of people are where so much rich information is about how the brain functions and which parts of the brain are crucial for these very human behaviors. So there were some stories that kind of always come to mind when we are trying to illustrate, for example, loss of empathy or gains in creativity, those kinds of things. But beyond that, it was trying to tell different stories in each chapter and highlight different parts of the brain, because at the end of the day, neurodegenerative disorders, we think, begin very selectively in the brain, very focally, and affect just one small area. But over time, they spread out and they affect the brain much more broadly. And so, although someone's symptoms at the beginning might be very specific and isolated, over time they develop lots of symptoms. So, a lot of the stories, like, if you follow people for years and years, it gets less clear as to, oh, this person had only this thing and that person had that thing. Like, the people really do develop many symptoms. But for the purpose of, teaching about the brain and the different neural correlates of social behaviors, we tried to simplify a little bit and talk about just the early stages of the diseases and disentangle those parts of the brain a little bit in our explanations.
And of course, clinical tales, I guess we could say, case studies, things of that nature, that's not new to clinical medicine or clinical science in terms of writing, especially for a public audience, not just for kind of fellow researchers or fellow clinicians. Obviously, I love to go back to Oliver Sacks, who I think most, neuroscientists, neuropsychologists, psychologists, and psychiatrists and neurologists have read in great detail as they were kind of going through their training and beyond. Do you feel like you were influenced by writings of people like Oliver Sacks and others, or did you want to take a sort of different approach?
Absolutely. We were both influenced by Oliver Sacks in particular, in addition to other neurologists who often write about these case studies in more academic journals. But I actually revisited some of my old Oliver Sacks books when we were trying to think about how to write these, and, just looking at his writings with a different lens of like, how did he put these stories together? We did focus a bit more on the anatomy of the symptoms. And, I'm a psychologist and Dr. Miller is a neurologist. So together we had this kind of complementary knowledge and views of each person we were talking about. So we tried to integrate that, which I think is not that common to see in a lot of these books for broad audiences, or even in academics. We work really closely in interdisciplinary teams here, which I love. And I think it allows us to make novel observations and have extremely interesting discussions and do innovative research. But unfortunately, it doesn't happen all that often, even in medicine. in this day and age. But we tried to bring that to the book in a way that, like you said, was kind of accessible to a broad audience, because we want the message to, get out there beyond academic circles, that the brain is important for how we behave and interact. And in addition to how we think, and it gets a lot of attention for its role in how we think, but still behavior and all the troubles people have with emotions and mood, the brain is not always considered in how we interpret those symptoms and problems.
Absolutely. And so, you mentioned that your focus tends to be on neurodegenerative disorders. This is a tough population. I personally, I think would struggle in that area. I have a lot of colleagues who work in that area, especially in like memory disorders or movement disorders, and sort of where they meet in the middle. I'm curious, what drew you to that population? Is it just because that's where you were trained and you started to, recognize that that there was like a rich questions that were yet to be answered, or did you have some sort of personal relationship with your clients or your patients? Was it all of the above?
Yeah, I would say it was a little all of the above. I mean, I was always very interested in what I thought was the intersection of psychology and biology. And so I always kind of walked that line of, bridging these two worlds. And, I worked in neurology, but I trained in psychology, and I really continue to walk that line. And it's a very blurry line. And, and like I said, we all work closely together. But I think I've always wondered why people behave the way they do, and how internal feelings, how we know whether what we feel is the same as someone else feels. If I say I have a headache, how do I know that's the same thing as when you say you have a headache, for example, let alone other more complicated states such as emotions. But I was interested in that, but I didn't have a personal experience with dementia or neurodegenerative disorders specifically. And that's where I think serendipity did play a role. And I landed in, at the time, a very early memory and aging center here at UCSF, which was being established. And I got very hands-on experience in working with these different patients with these disorders. And I got to see firsthand how they interacted socially, and how to me, it really did seem like emotions were playing a role, although that wasn't like a big topic of conversation at the time. Like they're not a typical thing to study even today.
No, I think some neuroscientists are not I shouldn't say are not interested at all. I think a lot of people are becoming more interested, but I think emotions have long been thought of as like a little more wiggly and a little less easy to pin down.
Yes. Still, I totally agree with that. And, every talk I give, I start with that and trying to define emotions, and just make the point that, just like any cognitive process, we have to define what we're talking about and measure it. And it's never perfect, and it always is oversimplified, but it's still, we still can learn a lot about the area. And over time, the more people who contribute to the knowledge, the more refined our understanding is. But that's the same thing as with other cognitive, constructs such as episodic memory or executive functioning. I mean, people talk about executive functioning all the time, but what even is that? It's so many different processes, and that also seems a little bit nebulous and vague to me. But we define these things, and then we make tests to measure them, and then we make conclusions, and that's what we do with emotions too. So I do think it's possible to study them and figure out how they rely or engage the body and the brain. But like you said, I think they do have like a not a bad reputation, but they are harder to pin down and make some people nervous to study them, I think.
Absolutely. And so I'm curious what kinds of, obviously there's a lot to talk about, and I don't want to just like go through the book chapter by chapter, but what kinds of discoveries or maybe things that people don't expect or that you wish more people knew do you discuss about that relationship between sort of the social emotional functioning and of course some of these neurodegenerative disorders or just for all of us whether we're dealing with a neuropsychiatric disorder or not?
Yeah, I think dementia in general also gets a bad rap. I mean, nobody wants dementia. It has a terrible connotation, a lot of stigma attached to it. But one message I think that we try to relay in the book is that these disorders and diseases are very slow, meaning years or decades of life. They can kind of very gradually progress, but as they're progressing, the whole brain isn't compromised until very late. And early on, it's very specific, in the problems. And that means that there are some things, we all can do to live more healthy lifestyles. And that does help how our brains function. But one thing we've also learned in these diseases is that as certain circuits in the brain weaken because of these disorders, others sometimes actually become stronger. And the reason for that is not totally well understood or understood at all, really. But and some people talk about compensation, like, oh, well, this system becomes stronger because that system becomes weaker. And I think sometimes that's the case, but other times it's just kind of another manifestation of the disorder, where the brain, the two hemispheres of the brain kind of can compete a little bit. And when there's a weakness in one side, there can be enhancement or strengthening of another. That's also true with different kinds of circuits. And so looking for the strengths and looking for the things that are preserved is so important to give people a sense of purpose and to keep well-being, high, to keep social relationships active. And all of those things really can shape and improve outcomes, even when you have a diagnosis of Alzheimer's disease or FTD. So that's like an important message we want to convey.
Did you know using your browser in incognito mode doesn't actually protect your privacy? Take back your privacy with IPVanish VPN. Just one tap and all your data, passwords, communications, browsing history, and more will be instantly protected. IPVanish makes you virtually invisible online. Use IPVanish on all your devices, anytime you go online at home and especially on public Wi-Fi. Get IPVanish now for 70% off a yearly plan with this exclusive offer at ipvanish.com/audio.
I think that also kind of, I don't know, at least in my very, very biased opinion, is a good sort of mark in the column of neuropsychology and, clinical psychologists working with individuals within these populations, not just medical professionals. And that's not to say that medical professionals don't approach their clinical work with like deep empathy. Of course they do, but just our managed care system is different, right? We get to spend more time with these people. That there's no question about that. And we are trained, I think, more in a strengths-based model, generally speaking. Some psychologists, are trained in a deeply, deeply medical model, but very often I think that our training does afford us the the lens of focusing on areas of accomplishment, of self-efficacy, and really highlighting those things in an effort to improve quality of life. Whereas very often clinical approaches from the medical side, from the physician side, are about focusing on, difficulties and deficits and treating those things with things like medicine. And so it's a dual approach that's really important. But without the psychology piece of it, I worry that would be lost.
Yeah, I think that's a good point. And we really do look for strengths. And I've noticed them when we find them. Often people try to explain them away, as like not like the real, part of the real phenomenon. And that's where I think they can be. I think strengths can be just as important or dependent on having weaknesses. Like sometimes you need the weakness for the strength to really blossom. In completely separate work, we've done research on children with dyslexia in collaboration with our UCSF Dyslexia Center, and we've looked at emotions in children who have trouble reading. And you might, wonder, why would you study emotions in children who have trouble reading? Those are completely unrelated. And yes, on the one hand, they may be unrelated. On the other hand, if you have like a whole brain approach, which is kind of how we think about it, if you have trouble in the reading systems in the brain, which are often in the left hemisphere, where language centers are predominantly housed, the idea when we first started the work was perhaps you would have enhancement of emotion systems that are primarily in the right hemisphere. And this is a pattern that we see in our older adults as well. And lo and behold, that is what we have found, is that kids with dyslexia have stronger emotions and even strengths in some of their other measures of resting autonomic physiology that we think help them to be highly attuned social and emotional beings. So, maybe the fact that their brain wiring just makes reading harder for them allows them to be this more nonverbal, socially attuned person,
Oh, I love that. I think that's it. There's probably so many unanswered questions when you start to view the individual and like idiosyncratic experience through that lens, that like these things that the, DSM calls literal, disorders, are actually much more multifaceted, and they may just be more types of being or types of thinking. And I think there's been a culture shift around looking at the autism spectrum in that way, and even ADHD and certain, we've started using words like neurodivergence a little bit more often than mental disorder. But I could see using that lens when it comes to a lot of diagnoses. That said, I also worry about the pendulum swinging so far in the other direction, that people don't seek treatment, or that, that really good support and really good medicine that is available is not taken or not utilized just for the sake of sort of wearing the label. So it's complicated, isn't it?
It is complicated, and we never want to downplay the struggles that someone has, but at the same time, recognizing that, a person isn't just about their weaknesses. We all have weaknesses, and looking for the strengths. I do think it paints a more complete picture. Some of the families that we've talked to, like parents who have kids with dyslexia, when I've presented the work, were so surprised to learn that, what they had already observed in their children, meaning that they were strongly emotional and sensitive, could be related to the dyslexia. That had never come up in any kind of psychoeducational or medical context. So yeah, I do think we can all do better in just conceptualizing people's strengths and weaknesses together in order to help them, figure out the best ways to navigate life, at an individual level, but also just to destigmatize some of these labels that are so common, in kids and also adults.
You know what else I think we could do better at? And this is maybe a little bit of a soapbox, but I'm curious to hear your take on this, especially as a practitioner of neuropsychology. I think we could do better as a society of A, educating the public what neuropsychology is, and B, like improving access to neuropsychological assessment and even, rehab medicine and therapy through that lens. Because I can't tell you how often I talk to not so much my colleagues in the hospital or, the patients that I work with, although there is some of that, but just people in my in my personal life, friends, relatives who are like, I think I might be ADHD. What do I do? Do I just tell my doctor? And then they will, and they'll get a script for Adderall, or like, I think I'm struggling with depression. Their doctor will write them a script for Prozac. And I'm like, oh my God, no, like we need to get you like a proper assessment so that we can see if that's what's actually going on in your brain, or if I don't think a checklist should be cutting it when it comes to diagnoses like ADHD, like autism, and the like.
Yeah, no, I totally agree. And it's tricky, right? Because, often the comprehensive assessments are very long and can be very expensive and very hard to even get onto someone's calendar. I've seen that many times over in, private practice kinds of situations, as well as medical centers. So at the same time, more comprehensive screening of various, learning differences or psychiatric conditions early in life or throughout the school age years, might help society to help people earlier. I mean, it's so tricky in childhood, knowing, whether a behavior in a child is normal or just a phase or truly concerning for mental health, in the long term. But yeah, it doesn't seem like we have the best way to track that at a large scale across kids from various backgrounds and, know how best to help them, again, kind of at that individual level.
Yeah, and I feel like it gets even worse in adulthood,
Right.
At least in school-age children who happen to be in a public school system, they may have access to a school psychologist, or they may have access to an IEP, and there may be some records about that their teachers have compiled, or that different professionals who are working with them have compiled. But as adults, I really do worry that so many people slip through the cracks who either had developmental disabilities that were never diagnosed, or who are developing later in life, as you mentioned before, like neurodegenerative diseases that, very often I think people are getting diagnosed way too late. They're getting diagnosed by their primary care physicians. They never see a gerontologist. They never see a neuropsychologist. And they're just kind of like put on Aricept and let's hope for the best.
Right. Yeah. And I think there's also a sense that it doesn't really matter knowing what they have. I hear that from friends too. It's like, well, my dad has dementia. Well, it doesn't really matter what kind it is because there's nothing you can do for it, and there is that mindset because treatments have been so difficult to find that it doesn't matter knowing the real cause, because even the fact that dementia can be caused by different diseases is an important point to make. People use the term Alzheimer's disease and dementia as the same term, right? And Alzheimer's disease is one cause of dementia, but there are other causes of dementia, such as FTD or other diseases or other causes that a neurologist and neuropsychologist can evaluate and kind of figure out which disease they think might be causing the dementia.
And that'll guide
but you
treatment,
need a
right?
specialist with that. And
like
treatments
you're going
are
to treat
coming.
vascular dementia way differently, or
Exactly.
Lewy body dementia way differently, and they manifest differently. So at the very least, you can help people be prepared for what's coming.
Right. And I think, in coming years, even in the past few years, there's been so much progress on the front of Alzheimer's disease that I think in the next decades, we will have more options that are more accessible. And there's going to be blood tests, or there are blood tests already for Alzheimer's that people will have access to, and even earlier and earlier. So we will need better plans that are tailored to the specific problem, and knowing what the cause of the problem is will be essential for getting that treatment right and the plan right.
Yeah. So I'm curious, we've kind of, it's interesting because we're sort of talking about two things that are deeply related in parallel. Number one is your research, the things that you've gleaned from your research, kind of these more global conversations around neuropsychiatric disorders or neurodegenerative disorders. And number two, this idea that we can better understand our kind of cognitive and affective selves through actual science. It's not a black box. It's not there's still a lot of unanswered questions, but it's not necessarily this like untestable ineffable thing. I think back, and I'm going to get a little inside baseball here. So bear with me if you are not a psychologist or if you're somebody who never took like a psychology course in at the university level or beyond. But I think back to like my early training in things like cognitive psychology. And I always struggled with my cog psych courses more than anything else. And it seemed odd because I was trained in neuroscience, like, oh, cog psych, that's in parallel. That should be easy because I already have this background. But I found that we were often talking about the same stuff, but through like weird metaphors and euphemisms. And we were ignoring the neuroanatomy. And we were instead saying, well, here's a phonological loop. And I was like, what the hell is that? And so I'm curious if you believe, like I think I did at one time, and I still do to some extent, that sort of neurobiology as a framework could be that unifying feature to all those different, think back to your history and systems courses, all those different approaches to psychology, all those different ways to try to make sense of why we think the way we think, why we act the way we act, why we feel the way we feel. Do you think neuroscience can be in some ways that sort of unifying scaffolding?
I do, yeah. And in clinical psychology, and you've probably encountered this too, many people aren't interested in the brain still, and I had professors say like, well, why do you even need to know about the brain? Really, how does it change how you treat a patient? And when they said that to me, I was stumped, and it made me really think about why I did think the brain was important to know about, which I have always thought. But like you said, I think knowing the anatomy of the different, brain functions and how they work together, it kind of constrains the possibilities of what, what might be causing someone to think or act the way they do, right? I could make up a million theories about it, or it could be a phonological loop, or it could be whatever other psychological process. But if I know the biology is like, oh, no, that's not how it works at all, I can rule out a bunch of my theories pretty quickly. But if I didn't know the anatomy, I couldn't, and they would all seem equally plausible. So I think like that helps me a lot, and when I'm interacting with, people in my work context, like the patients, but even people in my everyday life, I'm always thinking about the brain systems that it might be strong in them or weak in them. And, anything we learn about the brain in the context of FTD or dementia, for example, is not specific to FTD. It's like probably true for everybody, including you and me. It's like there's a circuit that's important for empathy. If I understand that circuit, I understand that if the tissue cell and the cells are dying in that system in a person, they're going to lose empathy. But if I have a friend who's extremely empathic, I also can probably guess that system's very strong in her, So it's not a different system. It's the same system we're learning about. It's just how it kind of operates and functions across people. So that always helps me just navigate life in general.
Absolutely. And I believe it's not an essentialist or a deeply fundamental system in the sense that, we talk a lot of big game about nature versus nurture, but there is no versus. It's right. They play off of each other. So just like an individual can experience the changes that occur in a neurodegenerative disorder, somebody whose brain maybe is stronger in these, like, let's say, empathy networks, that can be learned. And it
Right.
should be learned, right? Like it's not like women are just fundamentally more verbal and fundamentally more empathic. We are socialized to have to be that way because we live, I mean, this is my view because I'm very feminist in my approach, but because we live in a patriarchy that has very distinct gender roles that are placed on us from the time we're babies. It's not just, oh, this is how a woman's brain is. It's like, no, we trained our brains to be that way, and you can too.
Yeah, I think we talk about this in the book a little bit as well, but just like any physical skill or cognitive skill, like if you throw a baseball enough, like you can perfect how to throw a strike or whatever. If you really want to practice empathy, you can practice and you can put yourself in situations to try to feel more empathy or different strategies and techniques. I mean, there is a basic genetic predisposition where some of us it comes more easily than others. However, right, life experiences are crucial in shaping those systems, and we have a lot of power in molding them in how we spend our time and what we do in our day-to-day lives to strengthen the circuits that we want to strengthen.
Absolutely. And understanding that, I think, can be really helpful because there is a sort of, I think, cultural bias in some ways towards, well, there are things you can get better at and there are things you just are. And so why put effort into things you just are when you should be putting effort into things you get better at? And very often, I think, as a society, we get those things wrong. We take effort away from areas where we should be actively working on things like, for example, empathy. And we put effort into things that sometimes maybe aren't as appropriate, like like societal constraints, right? Like we believe that people can often pull themselves out of certain like social classes when the evidence doesn't show that the systems in place allow for that. So I do think it's a really interesting and like this kind of work is not just for the wonky esoteric clinicians who are like in this one area of academia and who are like spending time with this one population of people. It applies to all of us, and at least having a basic understanding of how the brain actually works and how that translates into how we are and who we are, I think can be not just empowering and validating, but it can also be really, I guess validate. It can help us accept ourselves in a way that if we don't have access to this information, we may struggle quite a bit with a lot of like self-loathing or a lack of efficacy. Like, why am I like this? It must be because I'm not, whatever enough. And that's such a bummer. Like I see that all the time. I work in a cancer center. So like you're working with neurodegenerative diseases. I'm working with individuals who have, developed this broad, I guess, class of disorders where your own anatomy betrays you, right? Where your own body cells start to divide uncontrollably. And all the time, one of the biggest things I work on with my patients, other than, end of life preparations and things of that nature, is like the why me question. And so often the what did I do? Is it because I didn't eat enough vegetables? Is it because, and it's so heartbreaking when I'm working with folks where it's like, no, you didn't do anything to cause this.
Yeah.
This is just how brains are. But I just don't think we have that basic understanding in the general public.
I agree. I think, that feeling of, self-blame is rampant. I hear it a lot from parents too. It's like, what did I do wrong? My child is doing this thing. And it goes back to the nature nurture, issue of like, well, sure. I mean, no one's perfect and we all probably could improve in whatever area of parenting, for example. But at the same time, there's also we don't have total control over any outcomes in life. And you can do everything right as a parent or as an individual, eating right, sleeping well, reducing your stress, having friends, all the things we know. And still, bad things can happen. You can get cancer, you can get dementia, and there's nothing you could have done to prevent it, unfortunately.
Exactly. But understanding the fact that that does happen and knowing what to look for and understanding the state of the kind of the science right now and the state of the medicine can empower you to recognize the signs early, to seek the type of help that you need, and to live a longer, healthier life with a higher quality of life, given what you do have. And I think that that is not, for some people, they might say, oh, that sounds so dark. Like, oh, you only have so much time left and let's just maximize it. But I'm sorry, that applies to everybody on the planet. Like, and this is something that I think is fundamental to my work, but I can see it in your work as well. We are all going to die. We all are mortal creatures. We are all going to suffer. And understanding the how and the why can actually empower us to make sure that all of us will have a shortened time, even those who live 100 years. Like we don't know how long we could live in a perfect environment. And so for whatever reason, we're all going to reach our demise. Maximizing that time and improving the quality of our lives is so important. And I don't think you can do it really without the type of information that you're disseminating in your book and without these kinds of realizations that people have about their own anatomy, their own sort of wetware, if you could call it that, the meat part of the person.
Yeah, I think often, it's so hard to know like why someone is acting the way they are. And like if someone starts withdrawing from their friends or family and they're in their midlife, and that's very unlike them. We all can make up stories and reasons about why that is. And sometimes those reasons are true. Like maybe they are having a midlife crisis, or maybe they are depressed, or maybe they are just feeling tired and not, motivated. But another take-home point from the book is that sometimes those changes are important to not just, explain away, and that maybe it is a sign that something is changing that person's brain that is worthy of, getting checked out, because a lot of these aging related disorders do begin as changes in mood and emotion and behavior, and not as memory and executive functioning difficulties. Those do come along, but often the very, very early changes are more in the motivation and mood kind of category. So I think that doesn't always happen, and it's not just normal aging. It is something to look into if you have concerns. And in the medical field, we all have to advocate for ourselves as best we can. So if you do have more information of like, oh no, maybe it isn't, even what my doctor thinks it is, maybe I want a second opinion, like really following your gut instinct, I think, and advocating for additional evaluation when you feel it's warranted is so crucial too.
Oh, that's such good advice. It's such an important point. And, I can't help but think about, I work in a hospital, so I'm exposed to this, but I'm also, a big fan of television that, taps into that. So for anybody listening who's watched like The Pit, for example, or who used to watch ER, or who has enjoyed like medical dramas and things of that nature, you probably know that if somebody who's never had a panic attack in their entire life, out of the blue, starts to experience shortness of breath, chest pain, sweaty palms, a feeling like they're going to die, the last thing I would do, if I was their psychologist and they were in a session with me and they started to feel like that, the last thing I would do is go, oh, it's just a panic attack. I would say, oh, this has never happened to you before. You're not used to these symptoms. We need to get you a workup to ensure that something's not going on with your heart, to ensure that something's not going on with your lungs, prior to us then looking at these psychiatric explanations of what's going on. Because what we don't want to do is miss something. And I feel like that kind of approach is very similar to what you're mentioning. If you start to see personality changes late in life, it doesn't hurt to rule out a medical explanation first.
Right.
We can continue to work on the psychological components of it. And don't get me wrong, medical, psychological are not two different things. They are two sides of the same coin. But specifically in these situations, if somebody's withdrawing, let's make sure there's not something going on with their brain before we assume that they are, just having a falling out with certain friends, or they're just in a phase of their life where they're way more into books.
Right. I mean, we all can change and grow, and no one is the same person they are at 20 as they are at 60. But right, we do have like relatively stable personalities over the adult, our adulthood.
Mm-hmm.
So yeah, if something is pretty noteworthy in someone's kind of relational style or emotional responsiveness, it can be a sign that something is going on in the brain. And again, even if you bring it up and you're dismissed,
Mm-hmm.
I would just again encourage people to keep asking questions and pursue it if you really think there's more to it than even a doctor might be giving credit to.
Completely agree. Yeah. If you are your best advocate, you have to navigate the system as hard as it is. If something doesn't feel right and somebody says, oh, you're fine, don't worry about it, but you really, really feel like something doesn't feel right, it's not a bad thing to seek another opinion, to ask for a different specialist, to continue on that path. I see it all the time, all the time in the hospital setting. And I think that it's, I'm always the most impressed with the folks who advocated for themselves and got the help that they needed against a very, very difficult system and structure. Yeah. And so I think that's great advice as well. Probably not what we thought that we would be ending this conversation with, but deeply important for sure. So gosh, for Virginia, I'm wondering, is there anything, there's a million things we left out, but is there anything kind of at the tip of your tongue, at the tip of your brain that you feel like, oh gosh, we can't go without making sure that this is said?
I don't think so. There's so much more, work to be done in this area. And what I've done is only scratch the surface. For my own, for my own questions, as well as for the broader field. But yeah, thanks for all your questions and interest in the topic. I hope that people start to think about their own actions and feelings as biological processes, as well as psychological phenomena. And I think by understanding that those systems more broadly, the kind of driving goal of my work over the course of my career has been understanding the biology of emotions so that we understand the biology of mental health symptoms, because emotions are at the root of so many, psychiatric and psychological disorders. And we really don't understand their kind of biological origins. So
absolutely.
That's all I'll say.
Yeah. So I want to thank you not just for all of the effort that you've put in throughout your career so far, all of the hard work that you've done, and also in compiling the stories for this book and sitting down and doing the hard work, actually, that is writing a book, but also for taking the time out of your schedule for sharing some of these things with us today, sort of whetting our appetites a little bit as well. Everybody, the book is Mysteries of the Social Brain, Understanding Human Behavior Through Science by Dr. Virginia Sturm and her co-author, Dr. Bruce L. Miller. Thanks so much for being here, Virginia.
Yeah, thanks so much for having me.
Of course, and everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.
Did you know using your browser in incognito mode doesn't actually protect your privacy? Take back your privacy with IPVanish VPN. Just one tap and all your data, passwords, communications, browsing history, and more will be instantly protected. IPVanish makes you virtually invisible online. Use IPVanish on all your devices, anytime you go online at home, and especially on public Wi-Fi. Get IPVanish now for 70% off a yearly plan with this exclusive offer at ipvanish.com/audio.